The current classification scheme for gastrointestinal neuroendocrine neoplasms involves using both the tumor histology, the Ki-67, and the mitotic index as parameters for placing a tumor within a particular category and guiding us in terms of what to do. There is a separate classification scheme that is used for neuroendocrine neoplasms of the lung, which use mitotic index and presence or absence of necrosis as their main distinguishing features, and their classification system does not include the Ki-67. So what the pathologic and clinical studies have indicated is that the tumor differentiation status is really the most important thing in determining if a patient is likely to be in the less aggressive G3 category versus the more aggressive G3 category. And it makes a difference in terms of patient presentation, because oftentimes the patients with the more aggressive, so the poorly differentiated, the higher the Ki-67, those patients oftentimes don't do as well. Their average overall survival or median overall survival is often quite poor, and they usually die in less than a year, whereas patients who are in the well-differentiated category and usually have a Ki-67 on the lower end of the G3 range oftentimes have a much better overall outcome with a median overall survival on the order of a number of years. There's also a difference oftentimes in their response to particular therapies, particularly platinum-based therapy. Platinum-based therapy is the standard for high-grade or G3 neuroendocrine carcinomas, but is probably not appropriate for patients who are who have a well-differentiated tumor or who may have a Ki-67 in the lower end of the G3 pathology category.